all the seniors, including our senior speaker, Dr. S K Sharma, the head of the endocrinology in Rajasthan. Just last week, we had very good 2 lectures about the initiation of the program of the obesity. Some people say that obesity is because of the hormones. Others say it is only the calorie misbalance. Others say this may be some other disease. So today we have 2 brilliant speakers to solve many of the problems and association of the obesity. One is Dr. S K Sharma. He is the senior most endocrinologist of the Rajasthan. He will be speaking and telling us about the various association of the obesity. Other is Dr. Anupam Prakash. He is the leading physician and metabolic physician from Delhi. He will be giving knowledge about how inflammation, this metabolism is responsible and is associated with the obesity. And this program, with the inspiration by the Dr. K. Parikh sir and Dr. Girish Mathur sir, has been started, and we hope that most of the audience will like it and will prove beneficial for the practice for most of the physicians. Before we proceed further, I will request Dr. K. Parikh sir to say few words for elevation of the morale of all of the speakers, me and all the audience. Dr. Parikh sir.
Thank you, Dr. Keswani, for nice words. It's my privilege to welcome all the delegates attending this very important CME on certificate courses on obesity. I would like to welcome our President of API, Dr. Girish Mathur, ICP Chairman, Dean, Dr. Jyotirmay Paul, and our learned speakers, Dr. S K Sharma and Dr. Anupam Prakash. So welcome to this second course of certificate courses on obesity. And our speakers today is none other than Dr. S K Sharma. Hello, S K Sharma, who is one of the very senior endocrinologists and the first endocrinologist of the state of Rajasthan. He is the person who has very importantly involved in dissemination of the knowledge to all the physicians, and the person who has taken this dissemination of knowledge to every corner of the India. The second speaker, Dr. Anupam Prakash, is a very dynamic physician from Delhi and one of the very important member of governing body of API. I would like to compliment and congratulate Dr. Prakash Keswani for organizing such a important certificate courses on obesity, which is a very important part of learning by every physician, because it is the reason, it is one of the most important cause for all the communicable or non-communicable diseases. So I think we'll be greatly updated to great extent with these certificate courses. And I think this is very important. Last year also, Dr. Keswani conducted certificate courses at the platform of Indian College of Physicians, and this time also he is doing. So I really a great initiative taken by Dr. Prakash Keswani, and I would like to congratulate and thank him for conducting such a very important certificate courses. So thank you very much and welcome to all delegates. Thank you, Dr. Keswani.
Thank you, Parikh sir, for your kind words, for boosting our morale. And now I will invite our own President, API, Dr. Girish Mathur sir, whose inspiration has been always with us for starting this course and for other CMEs also. Dr. Girish Mathur sir, please say a few words.
Thank you, Prakash ji. Dr. K. Parikh sir, our mentor, our inspiration in API. Dr. Jyotirmay Paul, Dean ICP, esteemed faculty of this afternoon, the senior most endocrinologist of Jaipur and Rajasthan, Dr. S K Sharma sir, Dr. Anupam Prakash, a member governing body and the leading physician and professor, Hardinge Medical College, New Delhi. I congratulate Dr. Jyotirmapal, Dean ICP, to take this initiative to start this very innovative ICP certificate course on obesity. My compliments are also due to Dr. Prakash Keswani, the man behind this program, for designing this certificate course so meticulously and for taking on board all the leading faculties from the country. I'm sure this certificate course on obesity will update practicing physicians on how to approach and control the menace of obesity and its complications, as obesity is a major global health problem and the risk factor for many diseases. I'm sure this course will benefit all the attendees. My best wishes for the successful program. Thank you so much, Dr. Prakash, for inviting me.
Thank you, sir. Thank you, Mathur, sir. Now the most dynamic, young, but energetic and Dean ICP, who has made a lot of changes in last 3 months after taking this charge, including the website and initiating this program and starting so many new things. I will like to invite Dr. Jyotirmapal to please say a few words of blessing.
Thank you, Professor Prakash Keswani, for inviting me. And this is really our privilege. And I welcome Dr. Girish Mathur, President API, Dr. K.K. Parekh, our mentor, and past President, past Dean API, our esteemed faculties, Dr. S K Sharma, Dr. Anupam Prakash, and especially I welcome all the delegates for whom the API and ICP has initiated this short certificate course to update our member to the highest level of advancement of the medicine. I especially congratulate Dr. Prakash Keswani taking this subject because what Dr. Mathur was at the beginning was saying that we have a concept that obesity is basically due to overeating. But today we learn from Dr. Anupam Prakash, so no, this is a basically inflammatory disease. So there is a multifaceted approach is needed to control this pandemic or this current century pandemic obesity. I hope this program will update our members, and also it is in our mind those members who have not attended this certificate, the proceeding that we are undertaking in the next couple of weeks. So I welcome all the delegates and esteemed faculties to please initiate the course. Thank you.
Thank you, sir. Thank you for your kind words. Now without wasting time, we will move towards the scientific agenda. And the first speaker is Dr. S K Sharma. He is the senior most endocrinologist from the Rajasthan, from Jaipur. And he will be speaking about the various hormonal association or endocrine associations of the obesity. Dr. S K Sharma, please you start with your deliberation.
My screen is visible?
Yes, sir.
Yeah. Yes, thank you. So, dear friends, good evening to all the doctors who are today attending this meeting. My special regards to Dr. Parekh, to Dr. Paul, and to Dr. Mathur, and many thanks to Dr. Prakash Keswani for inviting me here. So, dear friends, today we are going to discuss endocrine disorders which are causing or associated with obesity. So we know that obesity is a very important problem, and it is having a central role in the development of non-communicable diseases like diabetes, hypertension, dyslipidemia, cardiovascular disease, and even cancer. Prevalence of obesity is very high. Now we say that 20% of the population is suffering from obesity. This number is going to be triple in the last few decades. And prevalence data reveal only part of the problem, as BMI has been used as a single indicator for overweight and obesity. And if you measure abdominal obesity by waist circumference, then you find more and more people are having abnormal waist circumference. Unhealthy visceral fat and or increased body fatness is also present in a substantial amount of normal or overweight person. So burden of this obesity is huge. There are several endocrine disorders, including diabetes, insulinoma, Cushing syndrome, hypothyroidism, polycystic ovarian syndrome, as well as growth hormone deficiencies, which are associated with weight gain. The mechanisms vary according to the primary action of these hormones on the energy balance, adipose tissue, as well as other tissues. So endocrinologists are frequently consulted to advise on the possible underlying diagnosis of secondary obesity. So obesity is often associated with glucose intolerance, diabetes, dyslipidemia, hypertension, increased risk of atherogenic cardiovascular diseases. In contrast to primary obesity, obesity resulting from abnormal regulation of hormones tend to have a rapid onset and rapid progression. Endocrine obesity is associated with symptoms and signs of underlying endocrine disease, and understanding the pathogenesis, clinical features, and laboratory evaluations of endocrinopathies enable us or specify the treatment strategy that can be implemented to cure the obesity and related metabolic disorders. So secondary morbid obesity like BMI, which is very high, like more than 40, due to endocrine causes are quite rare. So it is not that huge obesities are associated with endocrine diseases, but these are having some conditions which are having hypothalamic disorders, which are leading on to this severe obesity. And an appropriate evaluation in the first step is in the development of treatment plan for the overweight patients. Medical history to evaluate the natural history of our development of obesity and etiological factors are involved. So we have to look at physical examination, laboratory testing, and treatment of underlying endocrine disorder. So we will discuss some of these common endocrine disorders which are associated with weight gain, obesity. So first important is hypothyroidism. We all know thyroid disorders are very common. The commonest cause of hypothyroidism is developing countries autoimmune thyroiditis, and in Western country it is associated with 2% of women. But in Indian context, we know that it is even more higher prevalence of hypothyroidism. Weight gain is a common complaint in patients who are suffering from hypothyroidism. Other features we all know include like general slowing down, mental depression, cold intolerance, constipation, dryness of skin, and brittleness of hair. Later, non-pitting skin edema like myxedema, periorbital edema, hoarseness of voice, sinus bradycardia, hypothermia, and delayed relaxation of deep tendon reflexes are there. So an increase in body weight associated with hypothyroidism may arise from body fat accumulation, water retention, and increased deposition of glycosaminoglycans. Thyroid hormone is required for the normal regulation of resting energy expenditure, and in hypothyroid patients who are receiving long-term T4 treatment, thyroxine treatment, who maintain a euthyroid state, a small change in daily doses ensure that serum free T4 concentrations stay within the normal range and were associated with detectable increase in our, you can say, resting energy expenditure. Serum TSH is inversely correlated with resting energy expenditure, and increased serum TSH levels are strongly and linearly associated with weight gain in several of these studies. Hypothyroidism and obesity, if you see the relationship, is also associated with cardiac wall stiffness, bradycardia, and depressed myocardial contractility, and reducing the cardiac output. A low cardiac output and a decrease in renal blood flow and GFR leads to impaired renal water excretion, which contributes to edema and weight gain in our hypothyroid patients. Hypothyroidism also causes generalized interstitial deposition of glycosaminoglycan, which is in turn leads to fluid and sodium retention. Hyaluronan and abundant non-sulfated GAGs, that is glycosaminoglycans, accumulated in many of the tissues, including the skin, myocardium, kidney, and vasculature in several of long-standing hypothyroid patients due to the reduction in the clearance rate and increase in the synthesis of this glycosaminoglycan. So this glycosaminoglycan, like hyaluronan, exhibits a remarkable avidity for water, thus causing the tissue to expand greatly. Restoration of euthyroidism by T4 treatment increases the resting energy expenditure and decreases weight, mainly by decreasing the lean mass and not fat mass. Thyroxine treatment normalizes the tissue composition and increases water excretion. If you look into the other interaction of thyroid hormone with other hormones, we know that lack of thyroid hormone leads to reduced growth hormone secretion and thus generation of IGF-1. Leptin is also involved in some of our hypothyroid patients. Leptin and thyroid hormone possesses the ability to increase the energy expenditure, and hypothyroid has been shown to be associated with rapid weight gain because of this problem. Another important thing is catecholamine. That is a hypothyroid state is characterized by decrease in adrenergic activity due to reduced responsiveness to cyclic AMP to adrenaline. This may relate to effects of thyroid hormone on cyclic AMP generation. And we all know that thyroid hormone accumulation in mitochondria and our major regulator of mitochondrial biogenesis play a role in proliferation, differentiation, and maturation. So synergistic action of catecholamine and thyroid hormone together result in threefold increase in the mitochondrial UCP1 level in the brown tissue. And once we have a patient with hypothyroidism, we have to look at this algorithm and we evaluate TSH on screening. If the TSH is normal, okay. If it is less than 10, we say that it is subclinical hypothyroidism. If it is more than 10, we say it is clinical hypothyroidism. We look at T4 also. And if the patient is having low T4 and more increase in TSH, then we look at symptoms, and then most of the time we know that these are the autoimmune thyroid disorders which are causing like Hashimoto's thyroiditis, and ultimately we have to treat these patients with L-thyroxine sodium. Another important concept in hormone disorders causing weight gain is hyperinsulinemia and obesity. Obesity and diabetes are closely linked with increasing worldwide, and in most of the patients with type 2 diabetes who are overweight or obese at the time of diagnosis, iatrogenic weight gain is not only unwelcome but represents an important clinical issue that can become a barrier to successful management. Unfortunately, insulin and several other oral anti-diabetic drugs causes increase in weight while we are treating our diabetic patients. In UKPDS, we know that in these patients who are treated intensively, they gained extra weight of 3 kg as compared to those who are on the conventional arm. Weight gain was seen with all the drugs except metformin, GLP-1 receptor agonist, and SGLT2 inhibitors. Weight gain was highest among those who are treated with insulin therapy. Weight gain in type 1 diabetes was also documented in DCCT trial. Those patients who are on intensive arm in type 1 patient in DCCT, they gained more weight, like 5.1 as compared to 3.7 in those who are on the conventional arm of injections, 2 injections per day as compared to 4 insulin injections given to the intensively treated arm. After 12 months of therapy, the inversely related intensively treated group has a weight gain of something like 10% above the ideal body weight. And about 6 years after follow-up of these patients, there was 5 kilogram more weight was accumulated by the intensively treated type 1 diabetic patient as compared to their counterpart. How does chronically elevated insulin or improvement on glycemic control in diabetes results in weight gain? So there is a defensive or unconscious increase in food intake caused by fear or experience of hypoglycemia. So patient want to avoid hypo, so they have multiple, you can say, eating in between small snacks. Increased insulin level in response to increased caloric intake promotes adipogenesis and lipid storage. So insulin is an important, like you can say, anabolic hormone. It causes proliferation of adipogenesis, and weight gain in treated diabetes may also result from correction of the glycosuria, which decreases the energy loss in the unit. So you are giving a very good control, and now you are taking care of glycosuria. Loss of calories was reduced or stopped because of your treatment. And because of that loss of calorie, now the patient is gaining weight. If the food intake is not reduced to compensate the improved glycemic control, we find that reduction in glycosuria will result in net gain in the weight. Subcutaneous administration of insulin may also contribute to weight gain in diabetes, because endogenously in our normal person, insulin is secreted by the pancreas and it goes to the liver, and half of the insulin is mopped up by the liver. But when you are treating patients by nitrogen, you can say from subcutaneous insulin injection, what happens here? You are producing a hyperinsulinemic rate. Possibly this increase over insulinization is occurring, and it is possibly this systemic elevated insulin level promote fat accumulation, which in turn increases the therapeutic, you can say, insulin requirement in our patient. Weight management, why diet and exercise is essential for all the patients with diabetes. We have some drugs now available which causes weight loss, like DPP-4 inhibitors are weight neutral. Metformin is considered to be weight neutral or causes small decrease in weight. But SGLT2 inhibitors and GLP-1 receptor agonists, these two group of drugs are there which are causing significant weight loss. Consider weight neutral alternative to medications for hypertension, depression, and other diseases that may be associated with diabetes. So you have a table here where you have options of changing the drugs, those drugs which are causing weight gain, whether the patient is suffering from diabetes or hypertension or other you can say like psychosis, etc. You have always the option of selecting some drugs which will be associated with less weight gain or may not be causing weight. Another condition, endocrine disease, which is associated with weight gain, is insulinoma. Although we know that insulinoma is not that common, it is a rare cause of rapid weight gain. Patients who are presenting with symptoms of hypoglycemia, secondary to excess and uncontrolled secretion of insulin in our insulinoma patient, may develop more weight because of continuously eating something or other. The symptoms are episodic and range from intense hunger, palpitation, and sweating to neuropsychiatric manifestation such as anxiety, confusion, and coma. And patients with insulinoma learn to avoid these symptoms by eating frequent meals, often high sugar snacks, which promote weight gain. Although insulinoma is not common, but it is associated with weight gain. Another important scenario in our endocrinology is glucocorticoid use. So the main biological function of glucocorticoid includes the suppression of inflammation and control of energy homeostasis. Excessive glucocorticoids from exogenous treatment, for example, for asthma or for inflammatory conditions, or from endogenous overproduction due to pituitary adenoma or ectopic ACTH producing tumor or adrenal tumor, may result in centripetal obesity along with sarcopenia, hyperglycemia, insulin resistance, dyslipidemia, fatty liver, hypertension, and immunodeficiency. Some of these complications of glucocorticoid excess, like Cushing syndrome, resembles the metabolic syndrome, which is associated with common form of obesity. So the mechanism of obesity in Cushing syndrome: cortisol act via intracellular receptor, glucocorticoid and mineralocorticoid receptors. These are the family of receptors which is seen in other conditions like thyroid and steroid hormone receptor family. Exposure of glucocorticoid stimulates adipocyte differentiation and adipogenesis by transcriptional activity of the key differentiation genes, including lipoprotein lipase, glycerol 3-phosphate, dehydrogenase, and leptin. So the chronic effect of glucocorticoids on adipose tissue lead to the characteristic increased deposition of central fat, and patient will have a lemon on a stick appearance where the limbs are thin, but the abdominal obesity, centripetal obesity is there. This may be related to greater expression of 11-HSD1 in the visceral as compared to the subcutaneous tissue. Hydroxysteroid dehydrogenase 1 is the enzyme which is responsible for the conversion of cortisol to cortisol, and it is causing increase in adipogenesis. So here you can see this thing is highlighted that in our central adipose tissue, you have more of this 11 beta HSD as compared to more of 11 beta HSD2 in the subcutaneous plane, and cortisol is converted into cortisol and lead to all the problem of excess of these glucocorticoids. So indirect mechanism also there in the glucocorticoid induced obesity, that is the effect on thyroid status. Glucocorticoids suppress the thyroid axis through the suppression of TSS secretion and additionally inhibiting the 5' deiodinase, mediating the conversion of thyroxine to triiodothyroid. We know that T3 is more potent than T4 in its action, and it is inhibited by steroids. Effect of growth hormone status is also there. Chronic hypercortisolemia leads to blunting response of growth hormone secretion to all the stimuli, and successful treatment of Cushing syndrome and a reduction of glucocorticoid level lead to remarkable weight loss, though often not back to the pre-morbid state. We recommend that testing for hypercortisolemia should be done, at least 2 tests, screening tests should be done. This is a very busy slide. I will just highlight the screening test in the form of overnight dexamethasone suppression test or midnight salivary glucocorticoid can be measured. And if these are abnormal, then we proceed further. So these are how we are screening the patient for hypercortisolemia in our obese patient. Hypothalamic obesity is also not uncommon, and here you find that hypothalamic neurotransmitters as well as pituitary are involved. So the acquired obesity infancy, those who are present from infancy, these are having genetic hypothalamic obesity syndrome. We are here talking about which are developing in the later part of our life, and you find that some of these diseases are responsible for hypothalamic obesity. Particularly, you find that craniopharyngiomas, which are gradually increasing size, may lead to compression on the hypothalamus and pituitary, and may lead to this hypothalamic obesity. And their surgical procedures which are causing damage to the hypothalamus and pituitary are also leading on to hypothalamic obesity. Morbid obesity developing in almost half of the patient with craniopharyngiomas. So the mechanism has been thought to be largely due to hypothalamic dysregulation of the feeding, leading to hyperphagia, obesity, and insulin resistance. The median hypothalamus, that is containing satiety center, synthesizes anorectic hormones such as POMC and CART in the arcuate nuclei and CRH and TRH in the paraventricular nuclei, and the damage to these neurons in the animal models lead to obesity. It has been suggested that craniopharyngioma patients develop hypothalamic obesity because their hypothalamic structures are insensitive to endogenous leptin also. And these elevated levels of the leptins are also playing their role. The combination presented a powerful drive towards the obesity. So dear friends, here you find that routine laboratory evaluation for endocrine etiology of pediatric obesity, unless the patient stature and the height velocity are not attended, is not recommended. If the patient is having an endocrine disease in pediatric patient, then look at the height. If the height is compromised, probably patients are suffering from endocrine disorders. But if the height is not compromised, in fact, in normal obesity, which is simple obesity, most of our young growing kids are having better height. So height is to be looked carefully, and if the height is compromised, only think of that the endocrine diseases like hypothyroidism and Cushing's are responsible for the development of obesity in our young patients. So growth hormone deficiency and obesity is also important linkage there. Growth hormone deficiency may be isolated or occurs as a part of multiple hormone deficiencies. This growth hormone deficiency often results from damage to the pituitary gland or hypothalamus caused by the tumors or following surgical resection or radiotherapy. Patients with growth hormone deficiency typically have increased abdominal fat, reduced exercise capacity, elevated level of total and LDL cholesterol, elevated triglyceride, and reduced HDL cholesterol. Patients with growth hormone deficiency have increased fat mass and reduced fat-free mass compared with a BMI matched healthy of around 6 to 8 kg. And this increased adiposity in growth hormone deficiency is centrally distributed, as it is associated with elevated fasting insulin level and insulin resistance. Reversal of growth hormone, this obesity is reversed by growth hormone replacement therapy. Last but not least, polycystic ovarian syndrome is now coming in a very great way. 10 to 15% of our young female patients are suffering from this problem. PCO is very common endocrine problem, and this may far most complex endocrine disorder associated with obesity. Diagnosis of PCO is made by excluding the non-classical adrenal hyperplasia, androgen secreting tumor, Cushing syndrome, and hyperprolactinemia, as well as hypothyroidism. Heterogeneous disorder of multiple etiology is considered to be a PCOS. The most prominent feature of PCOS is the history of this ovarian dysfunction, amenorrhea, and oligomenorrhea in pubertal onset. Between 38 to 88% of women with PCOS are either overweight or obese. The adiposity appears to play a crucial role in the maintaining and presumably precipitating the PCOS. Support for the pivotal role of obesity in PCOS comes from often dramatic improvement in menstrual regularities in response to weight reduction in women with PCOS. However, the cause of obesity in PCOS is not fully elucidated. Evidence from the family-based and other association studies clearly telling us that genes may also be predisposing to the obesity in PCOS patient. A likely explanation for the mechanism underlies the development of obesity in women with PCOS is the combined effect of genetic predisposition to obesity in the context of a Western environment of excess caloric diet and reduced exercise. And most women with PCOS have insulin resistance to a significant greater extent than in age-matched and BMI-matched controlled women, this disparity being more marked on the higher BMI. So this is how the PCOS patients are having more of overweight and obesity. So body fat distribution in PCOS is mainly central, and these patients are having high insulin resistance, hyperinsulinemia. And once we advise them weight reduction, there is a significant reduction in the weight of these patients. The cycle can be interrupted by dietary intervention and the insulin sensitizing drugs. Simple obesity and obesity associated PCOS is associated with increasing androgenicity due to generation of testosterone from androstenedione, which is mediated by 17-hydroxy dehydrogenase, and dihydrotestosterone from testosterone, which is mediated by 5-alpha reductase, and reduced generation of estradiol from testosterone from the androstenedione, and ostriol from 16-hydroxylated dehydroepiandrosterone due to reduced aromatase activity in these patients. So the hormones which are also involved in the regulation of appetite in PCOS, leptin is also playing its role, and hyperleptinemia has been shown to be contributing towards the lowering of sensitivity of the ovarian follicles to IGF-1 and resulting in anovulation and impaired regulation of human ovarian follicular function. Ghrelin is also known to enhance the appetite, and which is again causing some of the problem here in these PCOS ladies. Dysregulation of hunger, food consumption, and subsequent weight gain in PCOS may be related to lack of reduction of ghrelin postprandially, and achievement of weight loss and its maintenance in PCOS proved to be continuing clinical challenge of both patients and their clinicians. This is the approach of obesity associated hypogonadism in men, because we have seen patients who are developing hypogonadism. They are having decrease in testosterone, particularly our you can say andropause patients who are above 60 years of age and having decreasing testosterone level, decrease in libido, and their decrease in you can say sexual activity. These are the patients who are gaining weight, and here the testosterone deficiency is implicated in the development of central obesity in many of these hypogonadal patients in our male patients. So in conclusion, we say that obesity can be a manifestation of hypothyroidism, hyperinsulinism, hypercortisolism, and growth hormone deficiency and hypogonadism in some of our male patients, and in PCOS patient, which is associated with glucose intolerance or diabetes. This obesity is associated with glucose intolerance, you can say diabetes, dyslipidemia, hypertension, and increased risk of atherogenic cardiovascular diseases. In contrast to primary obesity resulting from the abnormal regulation of insulin, glucocorticoid, thyroid hormone, or growth hormone tend to have a rapid onset, rapid progression, and to be associated with symptoms and signs of the underlying endocrine disease. And understanding the pathogenesis, clinical features, and laboratory evaluation of endocrinopathy is enabling a specific treatment strategy and is often cures obesity and related metabolic disturbance. So dear friends, I will stop here. In the end, I will just highlight endocrine disorders are not the common causes of obesity, and extreme obesities are rare in our endocrine disorders. But whenever you have a patient's obesity, sometimes we have to exclude these common endocrinopathies like the hypothyroidism, like exposure to the corticosteroids, etc. Thank you very much. I will stop sharing, and over to you, Dr. Prakash Keswani.
Thank you, Dr. Sharma. It was really a wonderful talk. You give information about how hypothyroidism can cause obesity, how hyperinsulinemia can cause obesity, how insulinoma can cause obesity, how central obesity can cause various metabolic problems, and how central obesity in PCOS can cause hyperandrogenism. Really, it was a nice talk, and all of about that you are able to give this talk from the Ranchi airport. So thank you, Dr. Sharma, for your nice talk. And
So,
another
I was
thought
just
for the
that because I had to board the plane, so I will not be able to answer your questions,
So,
answers.
if there will be any question, already there were so many comments, including Dr. Anubhav Srivastava, that it was a very nice talk.
Thank
So
you.
there will be, if any questions, me and Dr. Anupam will try to give the answers, sir. Thank you, sir.
Thank you very
Thank you. Thank you, sir.
Excuse me, please. Thank you.
Thank you, sir. Another, the second speaker of today is Dr. Anupam Prakash. He is the leading physician and professor of medicine, Lady Hardinge, Delhi, and he will be giving a news site about the inflammation, metabolic syndrome, and obesity. He says it is not simply a calorie disbalance, inflammation, and so many other problems also are associated with the metabolic disease and the obesity. I invite Dr. Anupam Prakash to please start your lecture.
Well, a very good afternoon to everybody, and thank you, Dr. Prakash Keswani, Dr. Girish Mathur, Dr. Parekh, Dr. Jyotirmay Pal, and all other senior members of the API fraternity, as well as from Rajasthan and other delegates. Well, thank you. This is a topic which Dr. Keswani has given me, and it is not an easy topic, I would say. But yes, I will try to make it simple, and I will keep things simple, because this is probably far more common than what endocrine obesity is. And to understand the pathophysiology, that is very, very important. And that is what I will try to give you a glimpse of it. The coin has not turned completely. We do not know the end of it still. And we right now do not have any management options also for this. But yes, there are some insights, there are some plausible hypotheses, there are some dietary interventions which we can do. And a lot many things will develop in the current times or the near future. Probably a lot of research is on. There are some therapies also. So I will just try to go. I have written as inflammation, metabolic syndrome, and obesity. That was the topic given to me. I will proceed in reverse direction. I will start with obesity, go to metabolic syndrome, and the most difficult part, or the inflammation part, or the crux of the matter, I will deal later. But yes, that will be the most important part of the talk. So this cutting I always show, because this is important. 1 in 3 individuals in the world is either too thin or too fat. So this is important. So we have transitioned not only demographically, but from undernourished to probably overnourished also. So this is a very important aspect. I will not go into the details of these statistics, but yes, you should understand that global adult obesity prevalence in India is 4.9%. This is obesity. If you add overweight, which is 22%, so you have a very significant population at hand, which is at risk of obesity and obesity related health hazards. Now, this is the ICMR INDIAB study. Now, we are lucky enough that we have Indian data which is published, and the 4 main centers, which is the phase 1, which has published. And you can see this ranges from overweight and obesity to abdominal obesity, which is from 10 to 16% overweight, obesity on the top of it, nearly the same figures. And in Chandigarh, which is an urban city, and we consider it a very well-planned city, you see the obesity is 1 in 3, which is very high. And similarly, even if we talk of overweight or obesity, when we talk of abdominal obesity, you can see 1 in 5 individuals to 1 in 3, varying from Jharkhand to Chandigarh. And this is not an ordinary problem. This is a very significant problem. And these 3 things, overweight, obesity, and abdominal obesity, we will understand, because inflammation actually varies in these 3 situations. And this is what we will just deal. That is why I started with obesity. A brief definition. So obesity is just not excess fat, but it is excess body fat accumulation transforming into multiple organ specific consequences. So this is very, very important. We should understand that it is just not simply fat. Every week, every OPD, I have at least, because mine is a government hospital, and every week there are persons who will come. मेरा भाई छोटा है, ये बिल्कुल दुबला पतला है, इसको थोड़ा सा आप वेट बढ़ा दीजिए. And they don't understand the problem is here. Fat tissue, when it comes, then it doesn't go easily. And accumulation of fat with multiple organ specific consequences is what is dreaded. And this is what is the problem, the health consequences. as Dr. Sharma also said, PCOS. So that is one of the cardiometabolic manifestations. But there are a whole lot of other diseases also. Biomechanical, you have so many of these things ranging from GERD, dysmotility, lung function deficits, osteoarthritis, obstructive sleep apnea or hypopnea, apnea syndrome, and urinary incontinence, and the cardiometabolic, which we all dread and which we all are aware of. But apart from that, others also, androgenic deficiency, cancers, gallstone disease, psychological disorders, psychosomatic disorders are so common, psychiatric disorders. So this whole spectrum does take a toll on a patient. And this graph is, I usually keep this graph because this shows you on the left side, you can see the relative risk of death. And the weight is increasing as you go from left to right of this slide. And you can see the cardiovascular disease increases, overweight, yes, increase, and obese, mammothly increase. Similarly, cancers increase with weight. And not only cancer and cardiovascular disease, all other cause mortality also increases as males as well as females keep on putting weight. So this is important. This is an old study, but yes, it is still relevant today to understand that every ounce you gain, you add to cancers, you add to cardiovascular disease, and you add to your morbidity and mortality. So briefly just touching the measures, yes, this diagram shows it's correct. You have weight, which is very important, and the other thing is waist circumference. Yes, there are some people who prefer waist circumference ratio also, and yes, we do have bioimpedance tools also as research tools today, and it is important for us to understand the cutoffs for us are less than 23 for BMI. So we have a very thin range, 18.5 to 22.9, because even at this less range, we have higher cardiometabolic risk, which is a problem in the South Asian ethnicity that we have. Now, briefly, what is metabolic syndrome? Because that is the second term that was given in the topic to me. And with this term was originally described, or syndrome was originally described by Revan in 1988 as syndrome X or insulin resistance syndrome. It is also known as Revan syndrome. And it is a cluster of common abnormalities. And the important thing is that there is no known common cause. So it is considered to be lifestyle disorder, a metabolic disruption of the milieu, our body's milieu, and it reflects a sedentary lifestyle, overnutrition, and excess adiposity. I will come to the definitions in the last, but metabolic syndrome is associated with endothelial dysfunction, at which center point is inflammation, and again atherosclerosis, again endothelial dysfunction as well as inflammation contributing to accelerated atherosclerosis in metabolic syndrome. And this actually, the importance of this is that this indicates that your patients are going to have an increased risk of development of future cardiovascular disease as well as future type 2 diabetes mellitus. So this is important. And if you classify a patient in metabolic syndrome, what do you gain? It gives you a risk apart from the LDL cholesterol levels. That is the advantage of labeling the patient as metabolic syndrome. So you understand that there are other metabolic disruptions in this patient, and you should take care of the patient as a composite whole and not just of the cholesterol levels or the atherosclerotic cardiovascular disease risk. You also have risk for diabetes. So this is important. But yes, whether the components of metabolic syndrome add on or they are simply the equal the risk of the components, that we do not know, and the risk is probably static on that component. Now, these are the commonest definitions that we use for metabolic syndrome. The NCP ATP3. So there are components like obesity or overweight, hyperglycemia, dyslipidemia, and hypertension. Dyslipidemia, two components, hypertriglyceridemia and low HDL cholesterol. So these are 5 components. So you have waist circumference, impaired fasting glucose or impaired glucose tolerance, hypertriglyceridemia, low HDL cholesterol, and high BP. So out of these 5, any 3 are present, then it is NCP ATP3 classification or metabolic syndrome. But if you go on the right side, the IDF, as well as the WHO classification or the EGIR classification, sorry. The IDF classification says waist circumference has to be high. That means central obesity is sacrosanct, and then any 2 of the remaining 4 criteria. Similarly, the EGIR criteria, that means the European Association for Insulin Resistance, European Group on Insulin Resistance, they said insulin resistance is important, hyperinsulinemia should be there, and apart from that, any of those criteria, any 2 of those criteria. But yes, it is important to understand that the WHO as well as the EGIR criteria give emphasis on insulin resistance, which will require a testing. So that is why these are not commonly used. We either use the IDF criteria, which uses the central adiposity as the center focus, and 2 out of 4 are present, or the NCP-ATP3, which is much more generic. So 5 criteria, out of which any 3 are present, you treat as metabolic syndrome. So this is what we usually use as definitions of metabolic syndrome. Now, the last part or the major part of the lecture would be how inflammation has crept in. So inflammation is very important. The data that has accumulated, it is not a new concept. When I was in my undergraduate days, 35 years back, then also there was a role of infection, inflammation. At that time, chlamydia, H. pylori, they were considered to be the infective agents which actually may have a role in coronary artery disease and also in accelerated atherosclerosis. So the role of infection has been continuing over decades, last 30, 40 years. But yes, we have not found any sacrosanct evidence to the same. But today, in the last 10, 15 years, we do have some hardcore data to suggest, the evidence is robust to suggest that yes, we, with the advent of cytokines, the easy availability of immunoassays, we have studied cytokines and we understand what is the problem and how inflammation plays a role. Although we do not have a solution to that, but yes, there are some options. I will come to that later. So now this SAT versus VAT is not the tax that we have, taxation. It is the subcutaneous adipose tissue and the visceral adipose tissue. So inflammation I will cover in these segments, and I will talk a little about the adipokines, the leptin and the adiponectin. The cytokines I will just enumerate that we consider. And this ATM is again not the vending machine, the anytime machine that you can have anytime money giving machine. So these ATMs are the adipose tissue macrophages, which are considered to have a very significant role. And then I will talk briefly about the inflammasomes and the gut microbiota. And the last sequence is what actually is the therapeutic part also, although the therapy is still not devised. So I will move from the basic to the latest and cover all these things briefly. Now, in obese individuals, as I was saying, we have to understand normal weight, overweight, obese, and central obese. So it has been, so the central obesity or central adiposity or the visceral fat or subcutaneous fat, that is the area which actually is associated with metabolic disorders and cardiovascular disease. And it is more for visceral adipose tissue as compared to the subcutaneous adipose tissue. So the anatomy of the fat distribution actually impacts the level of risk. And this is very important. The abdominal adiposity, visceral adipose tissue has an increased risk of developing insulin resistance, metabolic syndrome, and it is considered to precede type 2 diabetes mellitus. And it is believed that the cytokine release from this visceral adipose tissue actually contributes to insulin resistance. The studies have been more about subcutaneous adipose tissue, but the whatever small studies or large studies are with visceral adipose tissue, the crucial role in inflammation of adipose tissue or obesity is proven with VAT and less with SAT. Even the MRI studies, they say that obesity associated metabolic disorders correlate more with the expansion of visceral adipose tissue and less with the expansion of subcutaneous adipose tissue. So don't take it that subcutaneous adipose tissue is increasing, it doesn't make a difference. It does make a difference, but even small increments in visceral adipose tissue are much, much more important than increments in subcutaneous adipose tissue. So what actually happens in adipose tissue? There is increased volume of adipocytes, there is macrophage infiltration, and there is inflammatory cytokines production. Now, this is very important to understand when the adipose tissue hypertrophies or there is increased volume. So there is some hypoxia, there is some adipocyte necrosis, and there is release of lot many hypoxia-induced factors, which actually invite the macrophages, neutrophils, eosinophils, and every inflammatory mediator, which actually then start releasing the cytokines and result in inflammation. So it is not just that fat is accumulating. Once the fat accumulates, the blood vessels do not accumulate at the same time in the adipose tissue. Adipose tissue is not very strong in the vascularity. And so there is some adipocyte necrosis in a hypertrophied or increased volume of adipocytes. So this results in necrosis, which is, I would say, fertile ground for invitation of macrophages and inflammatory disease. And this actually, over a period of time, the cytokines all are circulating in the blood, which actually have been assessed also, and they promote cardiovascular disease as well as insulin resistance. And the subcutaneous adipose tissue represents approximately 80% of the human adipose tissue, but VAT is more metabolically active. As I already said, visceral adipose tissue is what is much more important than subcutaneous adipose tissue, and its accumulation will predict obesity-associated mortality, as I said, cardiovascular disease, diabetes, insulin resistance. Now, the second component of the inflammation is release of adipokines. So briefly, I would just say leptin, yes. Obesity, I would not go into the details of all this because I do have time, so I will just go through. So circulating levels of leptin directly reflect the amount of energy stored in adipose tissue. So once adipose tissue proliferates, so there is more leptin. So leptin is actually acting at the hypothalamus, and it controls the food intake. So leptin is good for us, but the problem is in obesity, there is leptin resistance. So even if with the release of with the increase of adipocytes or adipocyte hypertrophy, there is increased leptin, but then that leptin is not acting on the hypothalamus, resulting in not suppression of food intake, and energy expenditure is reduced. This results in obesity and the sequelae of obesity associated problems. Adiponectin is the other part, the other active adipokine or the chemokine, which is released from the adipocytes. It is highly expressed in subcutaneous adipose tissue, and its level decrease with increasing body weight. So it has a negative correlation. Leptin has a positive correlation, adiponectin has a negative correlation, and adiponectin levels will be reduced. So in the liver, adiponectin actually improves insulin sensitivity. So with adiposity, adiponectin levels will reduce and they will promote insulin resistance. So adiponectin acts at number of tissues. It also acts at the muscles. It also acts at the liver. So adiponectin decrease or increase in body fat is not a good thing for the body. Now, this is just a slide. I am not going to do details because I know I will confuse everybody. These cytokines, this is the third arm. So we talked of the visceral adipose tissue. We talked of the adipokines. The third is the cytokines. So there are a whole lot of cytokines which are released from the adipocytes, from the macrophages, and importantly from the macrophages. And these macrophages, neutrophils, they release these tumor necrosis factor, interleukin-1 beta, IL-6, MCP-1, IL-10, and TGF beta, transforming growth factor beta. These are the ones which actually are pro-inflammatory, and they contribute to inflammation. So hypoxia within the adipocytes, resulting in stimulation of hypoxia-inducible factor, attracting of the neutrophils, macrophages, and release of then these cytokines is trigger for inflammation, which actually offsets a cascade resulting in the inflammatory process, type 2 diabetes, insulin resistance, and cardiovascular disease and atherosclerosis. So apart from that, I will touch about the three last aspects. So one is the ATM. So not the anytime money giving machine, but yes, it is the adipocyte tissue macrophages. So as I described, these are normally present in lipids in the adipocytes. But the problem is there is a shift. Normally, if you see, I have written normally 5% of the stromal vascular fraction in lean adipose tissue is macrophages. But what happens when diet-induced obesity is there? This number of macrophages increases to 20 to 30%. So 4 to 6 times the macrophages are there. And obviously what they are doing inside adipose tissue, they are releasing mediators. That is how inflammation is at the center point of the obesity related complications. Now, this is a very interesting concept which has come recently, and this is the two types of ATMs are there. I would say adipocyte tissue macrophages, there are two types. One is the alternatively activated M2, which are good for the body. They degrade the induced nitric oxide synthase and the expression of anti-inflammatory cytokines. So they are the good for the body. They stimulate scavenger receptors, they mediate phagocytosis, and they have arginase production, which actually degrades the induced NOS, nitric oxide synthase. But the problem is there is a second type of ATM, the adipocyte tissue macrophages, the classically activated M1 macrophages. they express CD11C. They are abundant in obese adipose tissue, mainly in the visceral adipose tissue, which is the culprit that we all say, and they secrete pro-inflammatory cytokines, which actually contribute to high levels of TNF and IL-6, and they're directly involved in insulin resistance adipocytes, as we already discussed. And as obesity occurs, as the number of macrophages increase from 5% to 20 to 30%, as we saw in the last slide, this M2 shift to M1 macrophages. And this is the problem. This is the center point why ATM or adipose tissue macrophages shift from M2 type to M1 macrophages is the crux of the adipocyte inflammation problem. The next component of inflammation is inflammasome. Now, this is, I am just covering for the sake of postgraduates also, which I am sure would be there. And this at times comes as a short note also. And many times, even delegates who are listening to this topic, they will listen and this will be just passed on as a term inflammasome. Now, this is again a multi-protein complex. So it is multiple proteins which are there. There are three components as I have written. So there are pattern recognition receptors. We must have heard about the toll-like receptors, TLRs. Similarly, there are adapter molecule ASC, which actually are apoptosis controlling molecules. And then there is the caspase 1 enzyme, which is there. So these are the inflammasome. These are bodies, components, which are having proteins of different varieties. As I said, three components, and they actually inactivate the active the pro IL-1 beta and IL-1 beta into their IL-18 into their active forms, regulating chronic inflammation and metabolic processes. So these inflammasomes are a number of types. One of the common ones are the NLRP3, which is there. I have written it also, yes. Inflammasome NLRP3, which is considered to be involved in genesis of type 2 diabetes and beta cell destruction, obesity, and atherosclerosis. Now, this I will not go into the details. It is a busy slide, but I have highlighted the things which I just want to show. Now, the toll-like receptors, TLRs, which are one part of the inflammasome, they are activated by variety of dietary factors, including, if you see the third box, ceramides as well as oxidized LDL, endogenous molecule, endogenous stimuli which are there. So these are inflammatory stimuli, dietary factors which are stimulatory, endogenous inflammatory stimuli such as ceramides and oxidized. They actually activate toll-like receptors and formation of inflammasome, and these inflammation actually then contribute to a chronic inflammatory process. So once these bodies are formed, protein complexes, they actually keep on releasing the interleukins. And the last box also you can see the downstream pathways of both TLRs activate the NF-kappa B and the MAPK to inhibit insulin signaling via the serine phosphorylation pathways. So this is how they promote insulin resistance and contribute to development of type 2 diabetes, atherosclerosis, and obesity-related morbidity. Now, this is just a diagrammatic representation. I will not dwell a lot into it, but I think these are last couple of 3 slides, and I have 5 minutes to go, so I will finish within time. So you can see on the right, on the top is the M2 macrophage, which is the good macrophage, and on the type is the M1 type of adipose tissue macrophage, the M1 type of ATM, and which actually is associated with, you can see the top half, the blue half of the slide. This is relatively less congested as compared to the yellow half, the lower half, and that is much more congested because there are so many mediators which are being released by the inflammatory macrophage. And if you see at the bottom, it is the westernized diet. So this is, I have taken this diagram from an article. So they say that diet which is poor in fiber is actually the culprit and can result in a lot many release of macrophages, and this shift from M2 to M1 and contribute to insulin resistance. On the right, you can see the insulin expression is lost. Those blue insulin which was being released is now no longer released. So the receptors are blocked. The insulin expression is not there. The insulin secretion is less. Alpha cell expansion occurs, and all this contributes to insulin resistance, diabetes, and atherosclerosis. You can see the GLUT receptors also, the glucose uptake also, which is occurring in the blue panel on the top on the left side. Again, that is also absent because of these receptors. So leptin receptor, IL-1R receptor, TNF receptor, they are all blocked, and they are all resulting in a pro-inflammatory cascade. So this is how actually shift from M2 macrophages to M1 macrophages results in an insulin sensitive tissue or a body tissues which are insulin sensitive to insulin resistant. Now, this is the last couple of slides, 3 slides, which actually talk of the gut microbiota and the role of gut microbiota in influencing the immune system and the glucose metabolism. And you can see this three-way, the trivariate thing is interrelated, and there is a lot of interaction with these, and one begets the other. So anything which goes wrong, whether the immune system or the gut microbiota, it affects the other two factors adversely. So this is important, and this is just the summary of the gut dysbiosis which is there. You can see on the left is the lean person, and on the right is the obese person. And in the lean person, you can see the adiponectin is there, adipose tissue is there, but there is less inflammation. On the right side, the adipose tissue is hypertrophied, there is much more inflammation, and there is more release of IL-6 and TNF alpha. And then it results in the gut dysbiosis is also shown. The westernized diet on the bottom is shown. And you can see this results in a leaky epithelium, resulting in the lipopolysaccharide and the encroachment of the gut bacteria into the body, and resulting in increased chances of inflammation as well as even sepsis in patients who are immunodeficient. And the bottom, you can see the lean phenotype has symbiosis, controlled pathogens, the butyrate producers, balanced short chain fatty acid profile, balanced energy harvest, and anti-inflammatory microbiota, appropriate immune response, and tight intestinal barrier. On the contrary, on the obese phenotype, because of dysbiosis, westernized diet, there is obesity also, there is leaky epithelium, there is more transition of bacteria, pathogenic bacteria from the gut into the body, there is increased hyperglycemia and increased inflammation. So this is the gut dysbiosis which we all talk about so frequently, and this is actually being adhered to also and being targeted also. So this is just the slide which shows that if you change from westernized diet to the high fiber diet, there is a whole lot of changes which are occurring in the cell, and which actually can reverse cardiovascular diseases, reverse inflammation, reverse dysglycemia also. So this is what is very important, and this was what I was talking about. There is no treatment right now for inflammation, but yes, if gut dysbiosis, which actually has been proven to play a role, but and even fecal microbiota transplant (FMT) does have a role. The dose is not standardized, and the molecules which are there, the microbiota which are there, the dose of those microbiota is yet to be finalized, and those trials would take a little time to have results, and probably then we may have some data to show that yes, these drugs can be used for treatment of inflammation, obesity, diabetes, and cardiovascular diseases. So I think that's my last slide. And yes, so thank you everybody. And rather than being worried over our weight, we should start shifting our diet to fruits, vegetables, and the like, so that we know what exactly how to control our weight, and these things will improve with time. Thank you so much. Thank you.
Thank you, Dr. Anupam. You have really put a good insight in the pathophysiology of the obesity. We usually think that adipose tissue is a pad of fat which increases weight or gives you insulation. But you have very well explained all the things, difficult things, in a very simplified way, that it also contains inflammatory markers. It can cause visceral adipose abnormalities and associated metabolic abnormalities and inflammasomes, and how gut microbiota is also involved with this. And this understanding of pathophysiology of the obesity and these inflammatory markers may help us further in management of obesity and avoiding many of the metabolic complications. Thank you, Dr. Anupam.
Well,
and
you,
these are not my comments. Many of the audience, including Dr. Geeta Arora, has put her comment that it was a very nice topic and very simplified way it was explained. Thank you.
Topic was very
Dr. Keswani,
very
can I
interesting
make a
also.
comment
Yes.
over here?
Dr. Ghosh, sir,
Yeah,
yes.
sure, sir. Sure, sir. Sure, sir.
Actually, we are getting lots of cases of OSS. This time, I think maybe more diagnosed. And it does. There is very good evidence that OSA is basically causing more inflammation in the body, and that is the product as metabolic. So reversal of OSA decreases the inflammation. Is this indirect evidence of decreased inflammation leading to decreased metabolic syndrome, sufficient
Definitely,
enough
sir.
that inflammation has got a very important role?
Dr.
Is my
Anupam, would you like to
point
put some light on this topic, this is
Well,
comment?
Well, Dr. Ghosh is
Yes.
absolutely right, but probably it is the
Thank you.
fat which is accumulated everywhere, which results in decreased lung compliance, which is also there in the oral, pharyngeal, and laryngeal tissues also, which actually results in the OSA or OSAS, whatever you can call, or hypopnea apnea syndrome. So there are so many nomenclatures. Now we are diagnosing more with the easy availability of sleep studies. And yes, sir, OSA I showed also obstructive sleep apnea is a manifestation, one of the serious manifestations of obesity. So inflammation does play a role. And again, you will have to go back to the last slide that I showed that diet and exercise will reverse fat loss, will reverse the your weight also and inflammation also, and contribute to OHAS is resolution. Otherwise, you have to go to for bariatric surgery only.
In
Dr. Ghosh,
androgen
we have-
deficient metabolic syndrome and diabetes mellitus consequent to that, can it be reversed by giving the androgen replacement? Is there any paper or results are there?
There
Sir,
may be
those
some
cases-
paper, but as such replacement with the androgen will produce the reversal is not seems to be very important. Yes, there was some paper that by giving some androgens, particularly in androgen deficient patients, can reduce the inflammation, reduce the truncal obesity, and can cause improvement in the metabolic profile. But as such, there are no large data which suggests that giving androgens can cause reduction of the weight or inflammation or diabetes. Dr.
I
Anupam,
agree with I agree with Dr. Keswani. Absolutely right. It has to be an individualized scenario.
Now, another subpopulation of metabolic syndrome is antipsychotic obesity and insulin resistance or metabolic syndrome. How do you address this population? Very, very difficult to treat because we cannot leave the drug, particularly quetiapine and olanzapine, which is patient, and they develop very fast a metabolic syndrome, obesity, and other complications. Is there any special way of treating this population of patients? Because we know that this will happen.
yes, sir.
It requires a
such a-
lot. Yes, sir.
Yes, sir. Dr. Anupam, you
नहीं
please.
sir, बोलिए
No, sir,
sir.
please, first you, sir.
It requires a lot of commitment on the part of the treating doctor as well as the patient and the social support, because you cannot put the patient off the medications, because otherwise the patient, you may lose the patient because of some other reason, and then also you are in trouble. So this is a necessary evil. Obesity or diabetes because of anti-diabetics, antipsychotics is a problem that is very difficult to handle, and at times you don't have any other option. But you will have to again individualize, and once the psychotic part is controlled, then you can again change the medications or start tapering. And so it requires a lot of motivation from everybody, all quarters. Dr. Keswani, sir, you were saying something.
Yes, yes, definitely. It is very difficult to manage these patients. You need a good motivation, and sometimes we can give good advice about the diet, lifestyle modifications. Even in some patients with olanzapine, which gets weight gain, we have prescribed metformin along with this olanzapine.
Yes,
But again, it is very difficult to manage these patients.
so these patients are also very difficult because the motivation is very low. The manic depressive or the ones with they are being prescribed. So the motivation, the diet, as sir said, the last slide, in these group of patients, lots of diet and exercise counseling may not be effective as the other spectrum of drug. So it's real challenging for the whole team to control the weight. Sir, your take on metformin, are there guidelines where we don't do Humaya regularly in these group of patients, but if we prescribe metformin along with, if the patient is obese and patient is on antipsychotic or like olanzapine, so would that be beneficial, or it will be ethically right to give because it's not an anti-obesity drug
As such, there are no guidelines.
Yes, sir.
So we cannot say it is ethical, but it has beneficial.
It
And
has been,
we have
yes.
seen many patients in clinical treatment. My thesis topic was on the obesity, and iso right at that time was being used. And I had a keen interest for managing obesity way back in 94, 95.
Sure.
And all of a sudden, isomeride was banned. And I had a good number of patients with obesity. You will not believe, with good diet control. And I used to prescribe fluoxetine because that causes some decrease desire for the
Appetite.
and metformin. And I have a record of reducing weight of 30 to 40 kgs. But that was in the young girls, marriageable girls. They follow your diet very nice. So I think ethically it is not permitted. There are no guidelines. Metformin can be used for the weight loss, but we can have some advantage in selected patients, particularly when we find obesity or truncal obesity or evidence of insulin resistance.
Yes.
Well, I will also agree with
Thank you.
unofficially, I would
Nice,
say.
good thing.
Yes, sir. Dr. Anupam, please.
नहीं डॉक्टर घोष सर बताइए सर हुक्म करिए.
No, kuch nahi, but very good lectures. And Dr. Keswani, I'm just congratulating the whole team for
Yes.
giving us a good piece of lectures. Dr. Sharma and Dr. Anupam, obviously directed by Dr. Keswani. Thank you very much.
This will go on continuing. Even your topic of OSA and psychological aspects are being taken care in this course also. Dr. Sanjay Saran, endocrinologist from Jaipur, will be taking care in later half. By
Dr. Shibendu Ghosh misfired, that means I was unnecessarily injured.
Yes. So we will have all these topics one by one. We will try to understand the whole of the obesity, right, starting from symptoms or now. And today we had very good information and informative lecture about the inflammation.
Yeah.
And of this, we do not still think that adipose tissue can cause inflammation.
Dr. Keswani, I've got a question not related to this. Probably I got a lecture with Dr. Om Gonda, who is working in some US institute as well as the Karolinska. There is probably FDA approval of some of the SGLT2 inhibitor for the decrease on the obesity. Is there any recommendation?
So, sir, as such for weight reduction, it is not so yet. But GLP-1 analogs, they are approved.
Yes.
You also know. And GLP for weight reduction, I am not aware, sir.
Okay.
Dr. Anupam, what is?
I agree with you, sir. I was at that point of time, I was just saying whatever prevention of diabetes trials have been there, metformin over the last, I would say 20-25 years, metformin has still been the corner point, center point, as Dr. Keswani was saying. Metformin has proven its role in prevention of diabetes. And so obviously there is some component of weight loss also, and it does have a action on the cerebrum, anorectic action on the gut also. So that does play a role, and that is why metformin actually does have a role, provided it is used selectively and monitored, and if there is no benefit, obviously stopped after a 3 or 4 month time duration. I was just saying that with Dr. Keswani. I would agree with him. His personal experience, I would say.
Thank you, Dr. Anupam. Thank you, Dr. Ghosh. Dr.
Thank you.
Many other doctors.
Thank you so much.
Thanks to all the audience. And we will continue with these lectures, series of lectures. And in next Sunday, there will be off. Then again, we will be meeting on the 14th from 2:30 to 3:30 p.m. We have two brilliant speakers again on managing other aspects of the obesity. And we will cover all the aspects, including OSA and psychological and cardiac findings or diabetes and treatment. So
one good thing of Dr. Keswani is that this type of webinar is very good, because we can ask questions, we can see you, and we can talk to you.
Yes,
this is most of the programs, this is not available. So I must congratulate for this also to your team.
But sometimes some persons have some noise, so other persons may get disturbed. So
stop it,
while giving lectures, others should remain silent. Yes.
Sure. So thank you.
Right, sir.
Thank you, sir.
Thank you,
Thank you very much.
Thank you, sir. Thank you.
Thank you, and all others.